Good morning. Mamie asked me to talk about contracting, contract negotiations, contract issues surrounding behavioral health benefits. So, a little bit of background. There's only so much you can talk about in contracting for behavioral health benefits because there's about 5 codes that pertain, but there are things you can talk about. So the first thing I did is I checked with Catherine to find out what she was talking about so we wouldn't be redundant, and she was good enough to share her comments with me before the meeting. And then I went to Mary Beth Bulte, who's with me today. Mary Beth is the Director of Behavioral Health for Mercy and for Employee Assistance Programs. She's been with Mercy about 18 years, and she works directly as a result of the new autism law with families and coworkers in Mercy that deal with autism coverage. So she deals with this on a day-to-day basis and can talk about some of the issues better than I can. But we're going to share this morning. She's going to do a lot of the talking, and we're going to speak to a number of issues that we talked about that might be relevant to you or to coworkers that you deal with. So the 5 issues we're going to talk about this morning are limited requests that we're seeing for insurance coverage following the legislation. The same thing that Catherine talked about, we've experienced, and we want to talk about that a little bit. We'll both speak to that subject. I'm going to talk about contracting for ABA therapy services a little bit. I will not talk about specific prices because I don't think that's appropriate, or rates, but I'll talk about contracting. And then she's going to talk about 3 other issues that she identified in dealing with our coworkers and the subjects that they have to consider in dealing with the coworkers, which you see on this list. So we'll get right into them, and as with Catherine, this is very open and informal, so if you have questions at any time, please interact with us, and we will be glad to take questions or any comments at the end as well. First of all, limited request. We at Mercy deal with about 38,000 coworkers and 59,000 members. That's spouses, family members who might have coverage through our plans. And Mary Beth monitors this, but we have seen limited requests for ABA services in the time since the legislation has passed. So why is that? Well, first of all, when we get requests for services, we have seen requests surrounding diagnostic testing, seen a lot of requests about information concerning the coverage, and we have seen some requests for ABA therapy. But we haven't seen a lot of them, a little bit more recently, but not a lot of interaction. And she and I talked about why that was. And one of the things that was paramount was confusion if a coworker had access to some donations, the family did, or charities, or some type of grant program. And Mary Beth is going to talk a little bit about that and a general lack of awareness that the coworkers have about the insurance coverage issues. Very good.
So first of all, we did send out information to all coworkers home. Anyone who was covered received information that this was a new benefit that was available to them and how they could get in touch with us should they want that. So the ability to educate our employees and families is a little bit easier than maybe what the plans could do. So again, we expected to have maybe a little higher utilization than what other people might be experiencing, and we just haven't seen that. And as we've taken phone calls from people and as we've reached out to folks that we're aware have been affected by autism, that is one of the things that we hear is that, well, you know what, I get ABA therapy right now through a foundation that I'm tapped into, or I participate in a charity walk and that money goes to a fund and I tap into that for the services my family needs. So that was new, and as I've talked to some other kind of plan leaders, they weren't really aware of that either. And yet that's what some families have said, and I'm not sure, again, if there's confusion that they can't do both. Or there's just this fear that if I go the insurance route, then I'm going to lose this. And if the insurance goes away, I can't get it back. So I think, again, that was a piece that was really enlightening to us, and maybe a small reason why we just don't see the requests that we had expected to see. So again, I think the basic lack of awareness that it's covered, or it may be covered, or how to find out if the self-insured employer that I work with has this coverage, and then just maybe a fear factor of, I have some services, I don't want those to go away, so I don't want to maybe mess with the Apple Card.
So there's an important point to take away on this. A lot of the things that we've experienced on charities and donations are some kind of gift to a family to cover the whole needs of the family regarding the autistic patient. The gift, in many cases, does not pertain to a specific ABA service. It pertains to the total needs of the family. In an insurance contract that an employer has, you usually have provisions about coordination of benefits. And that contract might say that if you get some funds from a certain federal or state or another insurance source, the payment here is secondary to that source. But that is typically for a specific service or set of services. If somebody's getting funds from a charity or donation that's related to the entire spectrum of needs you have as an autistic patient or for the family that's covering and seeing for the needs of their child, then you need to think about going to the HR person in the company and ask them about the coverage. Does that coverage stop you from getting donations or charity money? Would it be offset against the insurance coverage, or will it not be? In many cases, I don't believe it will be, because if it's a general donation for services that expand over a lifetime or a period of time, it may not be covered in that insurance contract. And the same thing would hold true for a self-insured employer, but they would have a different type of an arrangement as well. So don't assume, or help the families assume, that they can't get paid from two different sources. It's not getting paid from two different sources always, if the donation or the charity or the form of the donation applies across a broader spectrum of care. Question is, if we consider the insufficiency of providers, I think, yeah, all of us do. But in our case, we're bringing on more providers as we go and contracting with some outside providers. And I'm sure that has some application, Ginger, but in many cases, there is great confusion by coworkers and the fear that one thing is going to take away and limit the ability to get in coverage in the other arena. So we're not going to get this charitable contribution anymore if we seek insurance coverage, or we can't get insurance coverage if we get the charitable contribution. First of all, contracting is an arena that is different for some groups as opposed to others. If you're in a hospital or a health system or a clinic with a number of doctors, you're negotiating contracts with insurers that comprise a number of services and a number of billing codes. So you're doing something more or less en masse as opposed to dealing with just the codes for behavioral services. So how you negotiate rates as a large entity is very much different than it's going to be for those that are dealing with direct ABA services, supervision services, services of a paraprofessional, and the like. That's why there's a limit on how much you can say about this arena. You've got about, as Catherine showed, there's about 5 billing codes here, and I will describe 4 of them here briefly, but I won't get into the specific rates. The first of those is the one she showed on the crosswalk, the direct ABA services. That is a H code 2012, and that's the services of a board-certified behavior analyst or a board-certified assistant behavior analyst, and it's typically billed in 60-minute increments. That is the typical time unit, although some insurers use a different time unit. There is a rate spread for that service, and the rate spread is usually, in our experience, goes from a low to a high of about $20 to $25. It goes from the lower rates for an assistant to the rates for a master's or doctoral BCBA. Most insurers will pay the same rate whether you have a doctoral or a master's designation. You're a BCBA and that's what they pay for. But some differentiate between a master's and a doctoral designation. One of the complexities here is that one or two insurers do not recognize an assistant BCBA as someone who can bill for direct ABA services. They in effect recognize an assistant as a line therapist. So you've got an issue with an assistant in this category for one or two insurers. The next two categories are the H codes 0031 and 0032, which are billed in 15-minute increments. And this is for assessment treatment planning and for the supervision of a paraprofessional. Now, got the same issue with assistant BCBA here as you do for one or two payers. But the spread is reduced here. The low for an assistant is typically at one end, and the top end is about $12 spread, a maximum, in terms of the rate spread between an assistant and what you might get paid for a BCBA, whether they are doctoral or master's category. And lastly, the services of a paraprofessional, that's the H code 2019, is billed in 15-minute increments typically. And the rate spread is very condensed here. We see it within typically a $3 range from high to low. So these, and then there's group therapy services, which I didn't mention, which can be billed for any of these categories of providers, and I believe that's H code 2014. But that's the services that you're dealing with when you're dealing with behavioral services and the coding system for most insurers. If you're talking about medical services by a physician that are billed through a clinic, a hospital, a health system, whatever, then they are usually at a contract rate that's negotiated over a whole set of services besides behavioral health. They may be cardiology, oncology, what have you. So I didn't think that was apropos to today's discussion, but that's the type of billing ranges you have in ABA therapy. And you will have some issues when you have an assistant BCBA involved in the billing process.
This might be a little more controversial, but I think, again, the request of me was to be as honest as I could be about the things that we see. So, controversial or not, these are points that I wanted to make. So one is consideration that maybe plans have in dealing with agencies versus individuals. So again, if you're looking at it from maybe a plan's perspective or what have you, these are kind of pieces that are important. So when we contract, or when there's a contract made with an agency, a group, versus an individual, it allows for that one contract to cover multiple services and provider types. So obviously easier for plans to go that route. So just when Catherine was talking about kind of the plans that they were going after, they quickly looked at who are our big groups that we provide services to, and they couldn't go after everyone. They were looking at the big players first. The same could be said about a plan. A plan can't go after all the individuals who are doing ABA. They have to first look at what is most of our people apt to be seeing. Maybe they're talking to the individuals about who's providing their ABA, but they're looking at big groups first, or groups that can provide agencies first. There could be perceived protection by the plan regarding the patient safety. Catherine mentioned when they do credentialing, all the pieces that they and their organization go over when they're credentialing their own providers, right? They talked about the pieces that they look at. And likewise, that's what a plan knows, is that the groups, or I think you said agencies, are doing some of those pieces. And an individual, then, of course, the plan is having to do all of that. So there could be perceived protection of the individual and the safety of the patient. Could be, again, perceived increased quality regarding the training, the oversight that they may be getting through the agency that they may not be getting if they weren't part of an agency. I think a big piece also is just the transition of care minimized following a termination. So let's say there's an ABA therapist out there providing services and they move. And now the family needs someone else to provide those services, and it comes back to the plan to help us find that. Or is the new person that's going to provide the services that ABA therapist who's left town is establishing, are they part of that plan? Is it going to be covered? Now, if you're contracted with an agency, that's an easier piece, right? It's going to happen. The agency is going to hire someone else new, and it's going to be covered by the plan, or they're going to transition to someone within that agency. So again, that's just some of the things to look at, maybe from a plan's perspective, when they're thinking, how do I go about building that infrastructure to treat the folks that need to be treated for the autism? Again, maybe a bit controversial, but the economics surrounding frontline therapists, and Mr. Ashworth and I spoke a lot about this because this is, again, maybe more problematic for the agencies, but it's something that we think about for our own coworkers and their families, is that frontline therapist, it's tough to make it work economically for that frontline therapist and the plan or the agency they work for, because first of all, you know that the rate's pretty low. I think Mr. Ashworth shared with you what that range looks like for the most part. And so you're contracting at a pretty low range. You're having to compensate that frontline therapist, often giving them benefits. So you're tacking on what you're getting paid, plus what you have. You look at what I have to pay this person. What do I have to tack on for benefits? What's the cost of the, in your world, how you're overseeing them, how you're making sure that what they're doing is safe and so forth. And again, that time factor. So what we're seeing is that it's very hard for a lot of the agencies and the folks out there to make the frontline therapist piece work. But it's a piece that we all have to look at because that is where so much of the work gets done. So I'm not saying that we've got the fix for it, I'm just saying there is that struggle of the low paying, where they're doing the work. You have to pay benefits, you have to give them time. They have some downtime in their day, and yet you're not being reimbursed greatly for that. There's the oversight, of course, that the certified person is giving, the billing by them, all the extra costs that go into that. I think for us, the biggest piece is we've talked to frontline therapists and we've talked to the folks who are treating our families within Mercy, is just the complexity of the billing and the novelty of the billing. And again, I know since January, a lot's been learned by you all. Catherine talked about a lot being learned, a whole lot's been learned by the plan and employers, and yet, for a lot of the providers out there that we've talked to, they still don't understand a lot of the complexities of the billing. For some of you, I think you were able to much more simply once a month or maybe once every week or two write down on a piece of paper what you were doing, and you were able to get reimbursed for that. And now you can't do that through a plan. And if you, again, I think Catherine had mentioned, but if you don't use the right code, so I think she showed some different codes that different plans are requiring her organization to do. Well, if her biller accidentally uses a code that's the UBH's code, Optimum's code, and they should be using MHNet's code, or they should be using a different code, it's going to be kicked out. And that for you all is so new, and it's just, you know, banging your head against the wall saying, why am I not getting paid? And the plan is saying, you're not billing us. We can't pay you on that. I thought it was fascinating when Catherine shared that, you know, your group is doing it so all written right now. It's not electronic because, again, being a bigger organization, she knows I've got to get to the electronic in order to make this work better, and yet we can't do that yet. So we truly understand the providers out here that are not as large having that difficulty. And so, again, I think it's great how she talked about having kind of the crosswalk and the cheat sheet. That's really what all your folks have to have, so that they know if it's MHNet, I have to do this, and if it's someone else, I have to do something else. So I know all of you have seen the form that, right? You guys seen these? Do you guys know these? Some say yes, some say no. This is the form that many plans require you to use. And this is what Catherine talked about her team, for the most part, is doing, writing it right now. But ultimately, many other services that she and like Mercy does, it's just electronic. It's not having to be written out. But I talked to our provider relations specialist, who happens to be here today, and she does a lot of conversations with providers because, again, the novelty of this. And here's some items that were identified that can cause payment issues that you really have to be aware of. It's kind of like that cheat sheet again that Catherine talked about. On one of these forms, and if you don't have one, we'll make sure that you're told after lunch how to get those forms. But you have to make sure you're identifying who the patient is in one of the particular boxes. And then another box asks you for the patient's ID. We see over and over again that people put the parent's ID because they think that's the insured person. It's going to get kicked out. It's not matching what the insurance company is expecting to see. So it's going to get kicked back to you or not paid. There's also a place where you have to document box 24J, the rendering provider, and it has to be completed per the plan's requirements. So if you're not allowed via this plan to build the little a, you cannot bill by that person. You have to bill by the right person. Box 33A billing, we see this often, even not just regarding ABA, but the billing NPI must again meet the plan's requirements. It kind of talks about what Catherine said. One of her plans was requiring her to use an organization's code versus the individual provider's code, where her organization's used to using the individual's code. If she puts an individual's code into that particular plan's box and they required her to put the agency's code, she's not going to get paid. Okay? So again, I know it's cumbersome, but that's the piece where you have to have these cheat sheets so that you know what you contracted for, what that plan requires, so that you can get paid. And again, this was again a simple tip that my Donna Schmitz, who's here, brought to my attention is, your system may not be automated. Matter of fact, if Catherine's isn't, my guess is most of you do not have an automated system for this. But the plans, their systems are automated for the most part, right? Plans that are in here. So when you submit this, it has to be legible that a computer can read it. It has to be contained within the designated area. So if you're writing down an MPI and you decide to go to the next box because you wrote too large, the computer cannot read that. And it obviously has to be accurate, and it has to be filed timely. So I know it's kind of basic, but for a lot of people, guys, this is where the payment breaks down, is that we don't do this correctly, and the system is not going to pay you. It's going to get kicked back, and that's a piece that I know most plans don't want for your sake. I mean, one, they don't want to have to touch it over and over, but they want you to be paid for the services that you provided in the most timely way. So again, I hope that wasn't too basic for you all, but it's a big piece that we're seeing and that we talk to our providers about a lot. When we find out a claim didn't get paid, and as this gal from United talked about, she's not the payor, we're not the payor, but we get the information. So when a claim doesn't get paid, we're talking to the provider too to try to help them understand, why didn't you get paid and what do you need to do differently in order to get paid.
And the other piece that I was told, and I think again it was mentioned a little bit earlier, is that there are provider relations specialists or some term like that at every one of the plans. And one of another group that I talked to, a different plan, a larger plan, had said that you can also often call and set up a time to talk with them so that you can understand what are the issues and what are the breakdowns, and so that you can hopefully get that fixed. So don't be afraid, but you may have to just say, I'd like to set up a time with a provider relations specialist to help me with this, and get that set up so you can work through it.